I guide for all of our learning sessions. During the RCA2 session, we're particularly focused on learning from each other and on providing an open, transparent, and safe learning environment. The objectives for our expedition, RCA2, improving root cause analyses and actions, are shown on this slide. And the full schedule of sessions is shown here. It is now my pleasure to introduce the faculty that will be joining us for the next 3 months. Dr. Terry Fairbanks is the Assistant Vice President of Ambulatory Quality and Safety at MedStar Health and the Founding Director of the National Center for Human Factors in Healthcare. Dr. Fairbanks has served in many national and international advisory roles in healthcare safety and has authored more than 120 publications and a book on healthcare safety and human factors engineering. Dr. Fairbanks is a national and international keynote speaker and is listed in this year's Becker Hospital Review Top 50 Experts Leading the Field of Patient Safety. Dr. James Bajan is the Director of the Center for Healthcare Engineering and Patient Safety at the University of Michigan. His work is focused on creating solutions that will make healthcare safer, more effective, and more efficient for patients. Dr. Bajan is an elected member of the National Academy of Medicine and the National Academy of Engineering. Previously, he served as the first Chief Patient Safety Officer and Founding Director of the National Center for Patient Safety at the U.S. Department of Veterans Affairs. Both Dr. Fairbanks and Dr. Bajan were members of the core working group that developed RCA2. Joining them today are Drs. Catherine Kellogg and Seth Cravat. Dr. Kellogg is the Associate Medical Director of Quality and Safety at MedStar Health. She is a researcher and patient safety expert with significant experience applying human factors principles to patient safety issues. At MedStar, Dr. Kellogg serves as the liaison between the Human Factors Center and the MedStar safety team, integrating safety science into innovative safety interventions implemented across the system. Dr. Cravat is the Assistant Vice President of Safety at MedStar Health. He is responsible and accountable for all patient safety and risk reduction programs across MedStar. Under his guidance, MedStar has experienced a massive culture change, implemented tools and behavior of a high reliability organization, implemented a new event review process to evaluate serious safety events through the lens of safety science, and leveraged the value of increasing numbers of incident reports submitted by MedStar's workforce. So as you can hear, we have a really great group of faculty that will be joining us on all of our sessions, and we are very much looking forward to hearing from them. So now I will turn it over to them to get the presentation started.
Thanks, John. This is Jim Bajan. The way we'll be doing this today is we'll take turns as we go through the various sessions that will be coming up over the next few weeks. And in some cases, each one of us will be the lead discussant. But throughout it, if there's other comments from Terry, Seth, or Catherine, they'll jump in as well. And then at the end of the formal presentation, there'll be time for questions. And you've already heard how to go about doing that using the chat feature, et cetera. So with that, let's just get started. Everyone, I think, already is aware that the white paper, RCA2 Improving Root Cause Analysis and Actions to Prevent Harm, was a paper that was published several years ago by the National Patient Safety Foundation. And the way that came about was a little before that, I was on the board at the time and talked to Tejo Gandhi, who is the CEO of MPSF, and we managed to get the Doctors Company Foundation to sponsor this, to come up with a way to really try to make the RCA process, and really think of it as the event review process, if you want to talk about that way, go more smoothly, more productively. In this slide, you can see that during the we had the pre-survey learning, we sent this survey out, which many of you responded to, but certainly not everybody. And you can see there's a range of both proficiency, expertise, and comfort with dealing with event reviews, and that's both with it, both personally as well as in the organization in which you all work or are affiliated. And this is certainly not uncommon, and we see this quite often. I think many of the things you'll hear over the next several weeks will not be totally new. I hope they're not. Hopefully you've read it, so it shouldn't be totally new, but your experience in using it probably is somewhat limited. And this just presents a way, and we'll get into it a little bit more in a moment, about how to try to look at event reviews in a systematic way to make sure in the end you really come up with the answers that are valuable to you and, more importantly, to the patient in the future. So the learning objectives today, and pretty straightforward, is to, one, review kind of where the current state of root cause analysis is and why we thought it was necessary to come up with maybe a different approach or a more formalized approach that was standardized, and talk about how this might be done to really get to the ultimate goal, which is really how do we try to identify vulnerabilities in our systems so that, and then take appropriate risk-based mitigation steps so that patients are unlikely to be harmed while under our care. Now, RCA has been used for quite some time, certainly in the medical profession, but other places as well. And while it's a commonly used term, I think the understanding about what it means is quite variable and inconsistent. It's certainly clear if you read the literature and just in your own personal experience, maybe at different institutions, that there isn't a standardized approach. What one person calls an event review or RCA, root cause analysis, varies quite a bit, both from organization to organization, and even sometimes within an organization. Also, it's been the experience of many people that the solutions and countermeasures that have come out of these event reviews have often not really gotten to a systems-based level to understand the causations and how to implement them. And the implementation, even if the causes and countermeasures well thought out, often aren't done. And many organizations also don't follow up to see if what they did worked. So this means there's still opportunities certainly for improvement. So why do we take this? Because you would see in the literature various editorials or various papers that would look at RCA and use the term root cause analysis. They would use it in different ways. So while you might read the abstract or the conclusions of the summary, and some would say they've had great impact with RCA and really fixed things, or others said it doesn't work at all and it's a waste of time. If you really dove down a little bit more deeply into these various papers and articles that have been written, you'd see that in the methods section, if they describe it, that the way they went about it often was quite different. So you're really comparing apples and oranges. And in undertaking the RCA squared thing, and Doug Bonacom and I chaired this, and Terry was on this committee, along with many others, both medical people, physicians, nurses. We had representatives from the patients' advocacy groups. People from various countries were on board. We had Joint Commission, ECRI, who else? A number of other organizations who were involved with this, ARC. So we really had a committee that put this together and look at a very thorough review of the various literature been published to really dig into the references and everything else, and then come up with something we thought would work. So we thought in order to really get the sustained kind of results we needed, we had to get beyond some of the problems in the past. And I guess one of the first things, and it's actually mentioned in the introduction in the RCA squared white paper, is that the term wasn't even well used and well thought out. I think there's a Confucian saying that says the first thing in any endeavor is to call things by their right names. And right on its face, root cause analysis is probably not the greatest term, because on the one hand, root cause would tend to indicate by the singular nature of the term that there's only one cause. And I think we all know that there's a multiplicity of causes usually that underlie any event you're looking at. And the real trick is to understand what those are, which have the most likelihood of having an impact in the future, and how to prioritize those. So right on the fact that it says root cause, it made many tumble to the thought that only one underlying cause is the case, which is seldom ever the case. I would say virtually never the case. The other is that it ended with root cause analysis. And I guess I would say that to think it's just about analysis, that's not what it's about. If you don't actually convert it to actions, and how do we change things to reduce the likelihood that a particular issue would cause patient harm, then we've kind of missed the point. Now, I think everybody understood in root cause analysis they were supposed to be getting that, but why not have a term that made sense? So I think since 2000, the National Center for Patient Safety, the FDA, we used to talk about really should be root cause analysis and action, RCA2, to differentiate it. And then this committee, when we met, we decided that's what we call this, because the term root cause analysis had been commonly used even inappropriately, but we wanted to use a term that people would still kind of recognize, but also recognize as a difference. We used to often call it really should be WQ. What happened? Why did it happen? What do you do to prevent it in the future? But nobody would be used to using that term, so we decided to go with RCA2, and that's why we arrived at that. But it's really come up with a systems-based way of understanding the causations, because if you don't really understand the causations, then you are reduced to really kind of treating the symptoms rather than underlying cause, which often isn't going to get you the sustainable improvement that you would wish to have. I think also within this was the fact that this really implies a systems-based approach, and one that understands, the various things that come into play, and really kind of a human factors engineering kind of based approach to looking at these things to understand the link between both design, socio-technical aspects of the processes, et cetera, to really come up with actions that will give you the kind of results you want. So that's kind of why we went with this new term. And I think the other thing to think about, which I think is quite familiar to people that have worked with many of the IHI endeavors in the past, is the bundle. And to really think about this as a bundle, that when you look at all the components which you'll get over the next several weeks, you really can't pick just little pieces and say, I'll use that. In fact, I would recommend strongly against that, because this is a system, and if you don't use all the components together, then they're not going to all work together and support each other as they were designed. That doesn't mean you have to do it that way, but I think you should be very careful in making choices such as that, because if you decide just to do this part or that part, you might find you won't get the same success you would get if you took a more systems-based approach to the solution. The various steps are listed on this slide, and one of the first goals is to standardize the process. And standardize isn't the same as uniformity, but what it means is you're agreeing to do things in certain ways that allow everybody on your team or who you interact with understand what's to come, basically how the system works, so they can be most effective in trying either to help or assist or in some way be involved with what's going on. Another thing we'll talk about more is that it's a risk-based rather than severity-based. In fact, I'd say the vast majority of all institutions only do severity-based, and that in a formal way. And they just look at was somebody severely hurt or harmed. If you look back to the former Joint Commission reviewable sentinel event definition, it was somebody that had basic permanent harm or death due to other than the natural course of the disease. Well, I mean, certainly that's a problem, but there can be close calls or near misses, which actually let you know where a problem exists, and you would rather fix it before someone has to be hurt. I think that's common sense, and we'll talk about in the next session more about why that's important. We'll get into then about systems-based approaches and how to get past the superficial solutions that many people have seen in the past, where they'll tend to affix blame to an individual and then talk about, well, we won't do that again, or we'll fire the individual, or we'll tell people to be more careful, or write some new rule or something, which by themselves, if you don't get the stronger or intermediate actions, are really shown to not have long-term beneficial effects. So the elements are labeled here again, and we'll go through all these, and after today's session, the next one will be list-based prioritization. We'll talk about non-punitive, and what does that mean, and we'll go through these in just a moment. So when we talk about risk-based, we're talking about the severity versus the likelihood. And I think most organizations actually proceed in this way, but they don't formalize it and go through that in a way that is transparent both internally and externally, which can create a lot of problems about credibility with both the workforce and the staff involved, as well as the public and the patients. And it can put you in very awkward situations, and we'll talk about this in a great deal in the very next session, 2 weeks from now. We'll also talk about non-punitive approach and why that's important, and many people hear things such as blameworthiness or just culture, and this is all aiming at that, and how do you think about ways to make people more inclined to become involved with the event, both to identify the event for scrutiny as well as to participate in amelioration of the vulnerabilities that may have been detected. We'll talk about timeline and about why it's really an important thing to get, respond quickly, not just because of regulatory issues, but because the longer the vulnerability is in place and unmitigated, the more risk there is that someone will be harmed. And the longer this goes on, in some places have very bureaucratic processes that sometimes take several weeks to even decide if they'll do an event response, is really sort of irresponsible. And there's better ways of doing that, and we'll try to point out ways that we can react promptly in a well thought out way. This gives some of the things that are the high points in the white paper, where it talks about, we agreed, and all the things in the white paper, I should say, were unanimously agreed to by all the members of the committee that put it together. So it wasn't like a majority rule or a consensus. There was actually votes taken, where there was, we finally got to what's in there, absolute unanimity among all the representatives of various organizations. So we said, starting with the 72 hours, should be done with 30, 45 days, etc. So there was a great deal of talk about that. We'll talk more about that and talk about how to do that, the way the meetings would be run. And with that, that's kind of the high points. We'd like to open it up now for any questions or comments about these initial things, and then we'll also discussion from Terry, Kate, and Seth. So with that, let's look at the any questions or people raising their hand, etc.
Jim, this is Terry Fairbanks. While we're waiting for the questions to come in, I'll just highlight, I think in the introductions in the beginning, I want to frame the choice of faculty in that we tried to give all of you kind of the broad sense of perspective from people who are doing this in different ways. And so one thing we didn't mention in Jim's introduction is that he was one of the pioneers in the U.S. for forming this kind of approach, a more systems-based approach for a big system in how to do event reviews. And then we're all from, the other three of us are from the MedStar Health System, which is a 10-hospital system in the D.C. and Baltimore area, where we're three of the core people that have changed the way the system does RCAs to fit these concepts. So a lot of what we hope the discussion will be about is how do we actually make these changes on the ground in the health system.
Thanks, Terry. I see some of the questions that are popping up here. Here's one that somebody said, will we see practical examples of risk-based prioritization? And absolutely will, and that'll be in the very next session, which will be held, and it'll concentrate heavily on how does that work. And I think there'll be a lot of opportunity for questions, because this is something you really have to carefully look at the criteria you use for both severity and probability of occurrence, and how does that work. And I think the discussion there should be particularly rich, I think, as we go through this. I see there's some people who are saying they're having trouble hearing things. I'm not sure what the difficulty is there, but I know Christy's on and so is John, and they'll try to understand that. I see others are saying they can't hear. Are there any other questions that people want to pose either on the chat or hold their hand up so we can have them unmute them so they can just talk rather than write it in?
Hey, Jim, I have a question that you might be able to answer for some of our participants. I know you mentioned in the beginning that this is a pretty different process than a lot of organizations are used to, so I'm curious if you can talk a little bit from your experience, maybe some of the common challenges that you see organizations face as they're starting to get into this different way of doing things.
Sure, Joelle, that's a great question. I think one of the problems often is, and I saw one of the chat box. People asked about, the time limits and all. I think the big thing is to keep the goal in mind. And most people look at the value of the success of their RCA. I don't care how good any organization is, there's always ways for improvement. And if you look at some of those things, some of it goes to how quickly they get to really good systems-based solutions, and the RCA Square process actually goes through many criteria actually in a qualitative way, be able to understand, is this really a thorough review, both not just for the safety professionals, but also for management. Management should understand that as well. And I think when you start out with any organization, we, over the years, converted whole countries like Australia, New Zealand, Sweden, Denmark, just to name a few, NHS, how to look at these things. And we would look and say, where do they find they were coming up short? So they would, if an organization doesn't feel that there's any need for improvement, why should they change? Which I think is a logical and appropriate way to look at things. But in fact, I think most will realize that they could do better, whether it's in the identification of what the real problems were to what would be good solutions to can they really implement them in a sustainable way. So I think when you look for where there's ways to improve it, then I think that kind of opens the door to deal with some of these issues. As far as time, because people have asked that a little bit, we've been looking at this. I mean, when I was at the VA for 15 years, and they still track this, and I looked at their data, they would look at the amount of staff hours put into doing an RCA. So that's the people on the team, the time they put, whether it's in meetings or doing legwork outside the meeting, reviewing, whether it's technical papers, academic papers, looking at policies, reading charts, etc. And on the average for about 6 people on a team, they would use about between 45 and 55 staff hours over the 45-day period. So that's a little over than one man-hour a week. So it's not. It really is a fairly efficient way to do a fairly good way to get it done. The people I see are asking, can they, how do they get started in 72 hours? And we'll talk about this more later to not steal too much time from the later ones. But there's a lot of different techniques you can use, and many people will use, and it'll be interesting to see what Terry, Kate, and Seth say. But, some places will use, except for the leader or the patient safety manager, they will use different people, both lead and actually perform as team members by giving them some just-in-time training that lasts from 1 to 2 hours, then equipped with tools like are pointed out in RCA Square. They can do a very competent job, and this brings fresh eyes to it, for one. It gives you credibility because you have people that are out in the real world doing things that do it. And it also equips them when they go back to their job, that they have firsthand experience, and actually it's a way to proselytize among the workforce. And if you think about it over a year or so, if you're having 6 people on a team, you do, say, 10 a year. That'd be 60 people that intimately understand and help spread the word rather than strictly safety and quality people, which might be not looked at quite as in this trusting a way, only from the standpoint that obviously the safety and quality people are going to be enthusiastic because it's their job. But when you have the people actually doing the job every day are also enthusiastic, it's much more influential with the workforce in general. I see there's other questions. We're getting into the meat of business about how do you who do you involve, and we're going to talk about that more later. We really don't want to steal a lot from that if we don't have to. Terry and Seth and Kate, or any other comments you want to make about this as we're going on?
Terry, I want to give Seth and Kate a chance, but one other big picture piece of what you said in one of the earlier slides, Jim, that I want to reinforce is that we really want to see the RCA Squared help organizations move to a proactive stance. Because the ultimate, when people talk about getting to zero, the ultimate way to do that is to understand where the risks are before anybody's injured. And so Jim said quickly that these should be used not just for when there's been a severe injury. Of course, we do always have to do that and put resources in when there's been an injury or death. But one of the goals is to use this kind of process when there's been a near miss or a recognition of a vulnerability or a hazard that has a likelihood of causing a significant injury. And so think about that as you go through the idea of trying this in your organization when there has not been an injury. Seth and Kate, do either of you have comments or thoughts that came out from Jim's piece? Either they don't or we can't hear them, Jim, so I move on.
Okay. I'll wait for them to jump in. If they do, I'll just shut up. But Terry made a very good point there. I see some of the questions, and I know this is a webinar and all, but I would, by some of the questions, and we're certainly going to handle these. These are also handled very, both in the main text of the RCA2 white paper and also the appendices, which, the paper, the whole document is 41 pages long, and the first 20, I'm looking at it as I'm talking to you, the first 22 are the overview, and then the last just under 20 pages are appendices that have tools there, and then actual description and application of how these tools are used throughout an exemplar case. So I really strongly recommend, and I can't say it enough, while nobody's going to check if you read it or not, it's already clear from some of the questions that people haven't read the white paper at all, or they would probably be asking the questions. So while we're going to discuss these in great length in the various sessions to kind of go through them, each one and have discussions, I think the discussions will be much richer and will be much more valuable to you if you really take the time and read the RCA2 white paper thoroughly, because as in any other thing, this requires expertise, which is both the book learning and then actually applying it. But to think you can just listen to the webinar or just read the paper and not really think about it and apply it, and then be able to do it successfully, I think the answer will be you won't. And I think that's one of the things that stands in many organizations' way, is that they don't look at safety and quality as a real job. It does take some resources. As I said, the resources aren't great. In fact, you look at most institutions, if you look at their budget, their entire budget for the revenue that they have in their institution, they most spend far less than 0.1% on safety and quality. But yet, if you go to high reliability organizations like in the aviation, the petrochemical industry, they'll spend 3, 4, 5, 7% of their revenue on safety and quality. And yet, in healthcare, we have results that are far from outstanding, and yet we put very little into it. And part of it has to do with organization. We have to realize it's real work, and it requires expertise and experience to do it. But it also requires the knowledge, and people have to be thorough in how they approach this, or not that they won't get any improvement, but I think they will not get the improvement they otherwise might realize. There's let's see. I'm reading the notes here. Joellen or Christy says Gloria has her hand raised. You guys can see that, not me. Can we unmute her so she can speak?
Hi, Gloria. We're going to unmute you so you can ask your question. Go ahead. Gloria?
I'm assuming it's me. I'm one of the Glorias on the line.
Okay.
The question I had is, in your white paper as well as in your slides where we talk about rapidly getting to an action plan within that 45 days, we have a certain situation where we actually were trying to use and model this, that just creating the finalized action plan was a much bigger deal because it was more of a system-wide. We couldn't just fix it in one area. It had to be fixed house-wide. So I'm assuming then that when you say the 45 days, that's if it's a more focused, obvious fix that can be done in one area, or do you extend it, or have a limitation of how far out that really should go if it's a house-wide safety issue?
That's a good question.
You.
Thanks a lot for the question. Let me be a little more specific. Certainly the way I would mean it. At the end of the 45 days is what you use. At that point, and both when I was in the VA system and here at Michigan and others, we would have gone through, understood the causation, looked at those, prioritized them, and then come up with a suite of actions that address the various causations and been prioritized as to what would be done. And we're going to go into this a lot towards the final couple sessions to what are good actions. How do you implement them? How do you measure them? When you assign actions, they're only assigned to individuals. You never assign actions to a group. Groups aren't responsible for anything. It's bad management. An individual, so everybody knows who's responsible. Doesn't mean there's not many people involved, but there has to be a primary point of contact. Somebody has the responsibility to get it done by a certain date with metrics by which we measure both quantitative or qualitative. What is the measure of success? How will we measure it? How often will we measure it? How will we follow it up? There's no reason that those things can't be done within 45 days. Now, that means that's the plan. That doesn't mean they're all implemented and proved now. There are some things that you'll have shorter term and longer term implementations, like you could look at things that you're going to maybe have a software solution. That might take several months or longer to develop and to put in place, and there might be shorter term things you would do that are maybe not information technology oriented. But that plan, the basic plan, could be laid out within the 45 days. So it doesn't mean they've all been fully implemented, but the plan and who's going to do what by when would be 45 days. Does that make sense, Gloria?
Jim, let me just add that's one thing for Gloria to that, and that is I think what we'll try to do for you throughout is compare and contrast the RCA squared approach to what I will call the traditional approach in RCAs, and then and it'll help all of you if you're trying to sell this change within your organization. And Seth Cravatt can speak a lot to that and may have something to add to this because he shepherded that change in our organization. But to Gloria's question, the problem with the old RCAs, the way they were done in many systems, is there would be a long delay for the first big meeting because there was a sense that every big leader, all the right big leaders had to be in the meeting as they progressed. And this would cause weeks and weeks to go by before even people had a sense about what had happened, or at least believed they had a sense of what had happened. So the 45 days is to motivate things to get closed in terms of an understanding and next steps. And to your point, Gloria, if there's a big system-wide change that's involved, it's possible in some cases that takes a year to implement. And as Jim said, as long as you have somebody responsible and you have a plan and accountability and funding for that, and there's project management or an accountability around making sure it happens, as long as that's all determined within the 45 days, and that meets the objective.
Thanks.
And this is Seth, and I agree with that. I saw a bunch of questions about the 72 hours before, and all of this has to do with the sense of urgency from your leadership, your organization. So the big things that we had to change really had to do with the sense of urgency. So reporting things early and then actually putting the resources in so people could arrive early. We like to use the analogy of the NTSB at a plane crash. And we learned this from our patients that when a bad thing happens to patients, it's like a plane crash for them. And we realized that we were responding slowly, kind of in our time on our schedule, and that didn't work for the patients. It didn't work for the